Welcome everyone. We're going to give people just a minute or so to join the webinar and then we'll begin. Welcome everyone. We're just taking a moment as people join the meeting here. We'll begin in just a moment. I did see a question. Everyone is muted, so you don't need to worry about that. Okay, we're going to go ahead and get started as people continue joining the room. Welcome to today's webinar on the role of health and wellness in recovery. We're thrilled to have you all with us. We hope this is an informative webinar for you. This webinar is sponsored by the Northeast and Caribbean Mental Health Technology Transfer Center, or MHTTC, which is housed at Rutgers School of Health Professions in the Department of Psychiatric Rehabilitation. My name is Ann Murphy, and I'm the director of the MHTTC, and I'll be facilitating the webinar today. Michelle, if you can go to the next slide. Thank you. The MHTTC is funded by SAMHSA, the Substance Abuse and Mental Health Services Administration, and its objectives are to enhance the capacity of the behavioral health and other related workforces to deliver evidence-based and empirically supported practices to individuals with mental illnesses. We encourage you to visit the MHTTC network website for additional information at mhttcnetwork.org. And there you can go to find your center and click on Northeast and Caribbean for the activities that are specific to our center. We also have an email listserv. If you can go back just one, Michelle, thanks. We have an email listserv, and we would love it if you would go to the link that we have on the slide and subscribe to receive our notices about upcoming activities, events, webinars, online courses, different products we're creating, etc. We try not to send out too much email. Next slide. We did want to let you know, so today's webinar is part of a series on recovery from serious mental illnesses. We've completed several webinars in this general topic, including recovery from mental illness, and then several webinars on different practices specific to this population, including permanent supportive housing, supported employment, and supported education, illness management and recovery, and a few others that aren't coming to me right on the top of my head. But on our website, recordings to each of those webinars and the slides used in those webinars are available. We have two more coming up over the next month or so, one on the role of religion and spirituality in recovery, and one on recovery within the Hispanic and Latinx community. So links to register for those webinars are also on our site. Next slide. We did want to ask, after this webinar is completed, you'll receive a link to a very brief survey that we administer in part to get your feedback, which we really appreciate, and in part to document for SAMHSA participation of individuals in our activities. So we would really appreciate it if you could take the minute or two to just complete that. Next slide. We did want to let you know that this webinar is being recorded and will be posted to our website later today or tomorrow. Next slide. So this webinar will be interactive. So our presenter may ask questions of you and encourage you to answer using the chat feature. If you can't see, I think most of you will be able to see the chat button at the bottom of your screen. So feel free to click on that and then type in the chat box to interact with our presenter. We also encourage you to type any questions that you have there, and we'll collect those questions and present them to our presenter at the end of the webinar. If you have any questions or any thoughts as you go throughout the webinar, please feel free to include them in the chat function. And I will just highlight there that there are options for who can see what you're putting in the chat. So there's a small arrow with a drop down. And if you want just the panelists to be able to see your question, so that would be myself, our co-facilitator, Katia Rivera, and our presenter, you can leave it at all panelists. But if you want your fellow participants to be able to see what you're typing in the chat box, feel free to change that selection to all panelists and attendees, I think is what it says. So we encourage you to interact with us and with each other. Next slide. Okay, we want to go ahead and get the webinar started now. So I'd like to begin by introducing our presenter. We're very happy today to have Dr. Michelle Zechner. She's an assistant professor at Rutgers School of Health Professions, Department of Psychiatric Rehabilitation and Counseling Professions. And she's focused her career on helping people with mental illnesses recover, and also providing support to families of those with mental illness for over 25 years. And she has a special expertise in health promotion initiatives. She's worked in a variety of community and inpatient settings, including nursing homes, outpatient mental health services, state psychiatric hospitals, and community services for older adults. In her current role, she's focused on the implementation of evidence-based psychosocial practices in psychiatric hospitals, developing and testing health and wellness promotion interventions in community settings, teaching students, training diverse mental health staff on best practice interventions for older adults with mental health conditions, and conducting research. Her research includes the development of programs focused on multi-domain wellness for people with mental health conditions, promotion of and adherence to physical activity in persons with mental illness, use of peer health coaching strategies, and identifying best practices for use with older adults with mental health conditions. She's also co-authored peer-reviewed and technical publications on health promotion and has presented her work locally, nationally, and internationally. She's passionate about supporting older people with mental health conditions to improve their mental and physical health. Dr. Zechner also presented a webinar for us last year, I believe, on older adults with mental illnesses, and a recording of that presentation is also available on our website. So with that, I want to welcome Dr. Zechner and turn the webinar over to her.
Thank you so much, Anne. It's great to be with everyone today. I have a few session objectives that I was hoping to cover today. We're going to talk about some common health concerns for people with mental health conditions. We're also going to talk about some social determinants and lifestyle choices that influence health and wellness. We're going to talk about wellness approaches to health. Sorry, you're going to get lots of wellness today. You're also going to review some of the relationship between health and recovery, which I really think is one of the most important things when we're doing health promotion programs for people with mental illness. And we're going to talk about strategies at the organizational, practitioner, and program levels to support health and wellness. So I'm going to start by asking you to provide some feedback. And we've got a poll. Hopefully we'll be able to get our poll up and running. And the poll question is, what are the most common health issues faced by people diagnosed with serious mental illness? And there's the poll. If you could go ahead and just click what you think might be the answers. I could see, this is very cool. You could sort of see it in real time, what's going on. I'm going to give it another couple seconds, so feel free to make your vote count, as they say. All right. So I see it's interesting. I think you all are kind of ahead of the game here because metabolic disorders and cardiovascular issues are sort of neck and neck, with cardiovascular issues slightly, well, now they're tied. See, just wait a second and all the numbers change. Actually, it is cardiovascular issues are the #1 cause of death, but the most concerning and common healthcare issues are metabolic disorders, cardiovascular issues, and respiratory disorders. So the most common cause of death for people living with mental illness is cardiovascular issues and cancer. But we do see an awful lot of metabolic disorders, respiratory disorders, and accidents. And these are some of the things that we're going to be talking about today. Thank you for participating. I don't think we need the poll anymore because we have a chat. And in the chat box, thank you so much, everybody, for participating in our poll. We've got a chat that I'd like to ask you what health issues are most concerning at your site. So you can type that into the chat, and Kati or Anne will give me some feedback about what you're saying. So take a second, just go to your chat box. What are the health issues most concerning at your site?
So we're seeing, Michelle, a lot of diabetes come up, obesity, respiratory issues due to overdose, more diabetes, HIV, weight, iatrogenic metabolic disorders, smoking, tobacco use, heart conditions, even in younger clients. Again, heart conditions, COPD, diabetes, high blood pressure, substance abuse. Let's see what else. Lots and lots of diabetes.
Yeah. And that is really something that we often do see a lot of, is diabetes. Thank you so much. So I'm going to move forward here. Maybe we can take the poll down, or maybe I need to take my own poll. There it is. Okay. Sorry, everyone. I'm learning. It's a learning time for us all. I just want to remind us about recovery, because we're focused on recovery orientation. And that's the aspect that I'm going to be coming at health promotion from today. So I thought it'd be helpful to just review quickly what Bill Anthony talked about in terms of recovery. And he was sort of a pioneer of psych rehab and started in the late 70s. And he sort of looks at it as living a satisfying or hopeful and contributing life, even with the limitations caused by the illness. It also involves developing new meaning and purpose in one's life as a person grows beyond the catastrophic effects of the mental illness. And I know many of you probably have attended some of the previous recovery talks, so those are great resources. So let's talk about, you all brought up most of the health concerns that I was going to bring up, and it sort of is reassuring that you're seeing sort of the similar things that we see in the literature and that I've seen in my practice. So let's talk about the health issues that people living with mental illness are likely to experience. Cardiovascular disease, or diseases related to the heart and blood vessels, are common. This can include high blood pressure, which puts people at risk for heart attack and stroke. Cardiovascular disease, as I mentioned, is one of the #1 causes of death for people living with mental health conditions. Diabetes and metabolic disorders are also very common, and this is partly related to medication risks and lifestyle behaviors, like living a sedentary life or poor nutrition options. And sometimes this issue is referred to, I don't know if you've ever heard this termed in terms of the diet, as overfed and undernourished, referring to high-calorie diets with lots of carbohydrates and few vegetables or fresh fruit. Chronic obstructive pulmonary disease, or COPD, is a chronic disease of the lungs that causes problems with airflow. And that's where you see people having difficulty breathing and coughing and wheezing. And this disease is quite common in people who smoke. And many in our population experience COPD, unfortunately. Also, infectious diseases are very common. There are higher rates of hepatitis A and C. Some of you mentioned HIV, and the rates of HIV are estimated at around 4 times the rate in people with serious mental illness as people in the general population. Also, syphilis is quite common. And I do want to mention, in terms of infectious disease, I would be remiss if I didn't mention the COVID-19 as well. If you think about the highest risk factors for developing this virus is, underlying obesity, diabetes, cardiovascular issues, and, breathing issues. And you notice that all of those are on this slide. So I think that our population is at significant risk for developing this infection. Obesity is quite common, as we know. A recent study looked at 10,000 people with a diagnosis of schizophrenia, bipolar disorder, or depression, and they identified 80% of that sample, which is a huge sample, 10,000 of people in the United States. Also, movement disorders are quite common. That didn't come up as far as I know, but we need to be aware of things like tardive dyskinesia, which is that permanent movement disorder caused by long-term use of first-generation antipsychotic medications, Haldol, for example. There's also extrapyramidal symptoms, which are the small tremors or fine tremors in hands that come about using medications. And I was just reading a report that suggests that Parkinson's disease overall is at higher risk in people, developing in people with mental illness. People with mental illness also have higher liver disease and gastrointestinal problems. And sadly, a lot of these health problems and multimorbidity occurs at a younger age. And that's, if you look at the picture here, you see a younger person, and then you see the face in front of it is an older person. For people with mental health conditions, they experience diseases of older adulthood sooner. And you may say that for many people living with mental health problems, 45 is the new 70. So their bodies are actually quite older, much older than their chronological age. So their biological age is older than their chronological age. So let's talk about metabolic syndrome for a second, because you all have brought up some of those issues. And I just wanted to briefly go over that. I imagine that most of us know what it is, but it's good to go over briefly. It's a clustering of interrelated factors that increase the risk for developing cardiovascular disease. And that includes abdominal obesity, hyperglycemia, hypertension, and dyslipidemia. So let's look at those briefly. Abdominal obesity, and that's really where the waist circumference is larger, obviously. And I should mention that people with mental illness are at higher risks for metabolic disorders as compared to the general population. And the rates vary, but it's generally understood that this population is at quite a large risk. So, and that's a waist circumference of larger than 40 inches in men and 35 inches in women. Also, hypertension, or better known as high blood pressure, there's often no symptoms, and checkups are really the only consistent method of diagnosing hypertension. And that's, the risks are family history, smoking, alcohol, obesity. Being African American is a risk, and also having an unhealthy diet. And those are sort of the general accepted limits for the systolic and diastolic values. And hyperglycemia, which is also known as high blood sugar. And the specific risks are when the hemoglobin values are greater than 6%, or the glucose is greater or equal to 100. And we probably see this a lot in the people that we serve and where we work. I've seen it a lot in the hospital and also in the community. But the symptoms of high blood sugar can include fatigue, thirst, weight loss, blurry vision, or frequent urination. So I imagine that for a lot of people on diabetes, when we have done some health promotion interventions in the community, I would see people with H1C values of like 14, which is extremely high, or 20. And in that case, you definitely need to encourage the person to try to get help immediately for their diabetes. Dyslipidemia. See, I had to have a picture of something fun here. This is like the kind of lunch that looks really appetizing, but is full of cholesterol. The risk criteria is greater or equal total cholesterol over 200, or the LDL of greater or equal to 100. High cholesterol is pretty common for many people, but there may be this risk over time. If a person maintains high cholesterol, this can lead to heart disease, but there's usually not a lot of symptoms to that. And the primary way to address dyslipidemia is by reducing weight, improving diet and exercise, and eating right, not the things that you see anything on here. There's like that, tomato way off in the background and the lettuce, and that would be okay. But take away the salt and the French fries and the burger and the cheese. Dyslipidemia is also related to psychotropic medication usage. So for some people who eat a very healthy diet, they may still have high cholesterol related to genetics or related to medication usage. So let's talk about premature mortality for a moment. We've talked about some of the common medical conditions for people with mental health conditions, and now let's sort of understand a little bit more about the premature mortality. All of these health problems result in high hospital costs, readmission rates, and higher total health sector costs for people with mental health conditions as compared to the general population. There are lifestyle habits that can contribute to poor health, which we've already talked about some of them, such as smoking, sedentary lifestyle, and obesity. However, there are also higher risks due to accidents that occur while a person is experiencing psychotic symptoms or as a result of other substances. People with mental illness are at risk for higher rates of suicide, particularly during and immediately after psych hospitalization related to symptoms and depression. As we mentioned, there are impacts on medication and metabolic functioning, particularly the second generation medications. And people have already mentioned this is called the iatrogenic effect of medication, where taking the medicine actually causes harm to the person. Medication also can increase the risk of obesity, diabetes, and liver-related problems, and arthritis, things like gout. Access to quality healthcare contributes to improved and reduced mortality. We've been doing some research in this area with other health care professionals, and we note that healthcare professionals may have negative attitudes about treating people with mental health conditions, and I suspect you all have seen some of that in your settings. And healthcare providers may prescribe fewer diagnostic tests, believing that psych symptoms are causing the physical complaint. This complex interplay of stigma means that people living with mental illness receive reduced quality and care. So let's talk about these risks for a second. Lifestyle risks are the daily habits related to our health that either support us or put our health at risk. People living with mental health conditions have poorer nutrition. They may live in neighborhoods without grocery stores or only convenience stores with limited vegetables or fruit. I remember working with a group in Atlantic City in New Jersey, and they had groups to talk about what could you get at the local convenience store, because there was no grocery store at that time within walking distance or easily accessible for people living in downtown Atlantic City. Additionally, medications may make people crave carbohydrates like pasta, potatoes, chips, or bread, or make them feel hungry. Medications make people feel tired and sleepy, and drinking caffeinated soda may help to counteract that effect. You may have seen this too, but I've seen people just carrying around 2-liter bottles of common products like, Mountain Dew or Coke or something like that, and just drinking multiple 2-liter bottles of sugared caffeinated soda all day to counteract some of those impacts. Smoking is a significant problem. I worked on a project to develop a manual for smoking cessation a while ago called Learning About Healthy Living, and I learned a lot about smoking in people with serious mental illness. This population consumes a significant proportion of cigarettes sold and are much more efficient when smoking because they inhale more deeply. There is some suggestion that nicotine is helpful to manage the symptoms of schizophrenia. But sleep is another area that has an impact on health. People with mental health conditions may experience difficulty falling or staying asleep because of symptoms or caffeine intake. But we know that sleep is critical to help the immune system stay healthy and well, and it impacts our ability to concentrate and manage our moods. Another big area of risk for health is the high likelihood of sedentary behavior. Sitting has been called the new smoking because it's, believe it or not, sitting is actually as bad for our health as smoking. People with mental illness are less active than people in the general community, with very few likely to reach the goals of 30 minutes of moderate exercise most days of the week. This impacts thinking, metabolism, muscle strength, and ability to live independently. I've also done some research in this area and found that the most important predictors of physical activity in people with serious mental illness are having confidence or self-efficacy that they can do exercise and setting personal goals or intentions to move more. Encouraging people to walk a little more or stand up once an hour is a great place to start. Finally, people with mental health conditions may use substances to self-medicate or cope with symptoms or other stressors. And substance use has been correlated to high rates of infection and accidents, which leads us to our next area of premature mortality, accidents and death. People living with mental health conditions have an estimated 2 to 3 times death rate that's higher compared to general population, with people with schizophrenia having a higher death rate than people living with bipolar disorder. Heart problems are the #1 cause of death, but the risk of suicide is also quite high for people with psychotic disorders, and highest during acute episodes of psychosis and right after hospitalization. The rates of suicide and heart problems may be hidden in the statistics because when a person with mental health conditions dies of an unidentified cause, research suggests that the cause is most likely suicide or heart disease. The lifetime risk of suicide for people with mental health conditions is estimated at 5 to 13%. However, some researchers put the likelihood of death related to suicide as high as 30%. Mortality rates from infections leading to death from septicemia and intestinal and peritoneal infections and peptic ulcers are very high. And several studies in both the US and UK have looked at mortality rates for people of color and whites and found that people of color have lower rates of death than whites. Some of the speculation about that is that there's a protective factor of culture, community support, and additional resiliencies, and less isolation and substance abuse. But it's really not clear if this is a measurement issue or some other kind of error. People with mental health conditions are at high risk for experiencing violence and being assaulted, which can cause physical harm. The Treatment Advocacy Center estimates that people with mental illness are 11 times more likely the victims of assault than the general population. People using substances and with more severe psychiatric symptoms are at the highest risk for assault. Finally, people who experience total brain injury or TBI are at high risk for developing schizophrenia. A study by Way et al. Found that Medicaid recipients with TBI had about 20% of those also had a diagnosis of serious mental illness, and that the group with TBI and schizophrenia had higher medical costs than people with TBI and no schizophrenia. So there are a lot of things to consider. Let's talk about psychiatric medications for a moment. This is probably a review for many of you, but I don't know each of you, and I don't know what you know, so I'm just going to review all the key points here. Some antipsychotic drugs like Zyprexa, Clozaril, Seroquel, Risperdal are associated with higher blood sugar and higher cholesterol and triglyceride levels. Many psychiatric drugs increase appetite and may lead to weight gain because people are eating more or feeling hungry more often. Medications are one of many factors that can increase the risk of metabolic syndrome. Antipsychotic medications are often prescribed long-term and may increase the risk of diabetes and heart disease, with problems like arrhythmias, blood clots, hardening of the blood vessels, and sudden cardiac arrest being common in our population. So we touched on this a little bit already, but people with mental illness are one group with the highest disparity of care, meaning that they are less likely to have a primary care doctor and less likely to receive quality care, less likely to receive preventative care, and more likely to get care only from emergency rooms or other emergency providers. Unfortunately, there are some groups of people with mental health conditions who experience even less care than others. So the disparity within the population of people with mental illness, there's actually groups that receive even less care. And that includes people of color, rural populations, people living in poverty, women, and people in the LGBTQI community. This institutional stigma affects the way and the type of care a person is likely to receive. For example, there's some studies that suggest that African Americans are twice as likely to be hospitalized than Caucasians, with Caucasians receiving more mental health treatment in the community. So all of this leads to sort of a cascade of poor health, with the iatrogenic effects of medications combining with lifestyle behaviors to create high risk for health conditions, which then leads to worse overall health. There is less access to quality health care, preventative medicine, and screening to address these health problems. And combined with possible stigma of health providers, this all leads to increased morbidity or health problems and a higher risk of mortality. We have to include the social determinants of health in any discussion about health promotion in people living with mental health conditions, because there's likely to be so many issues that fall under this factor. The social determinants of health are a framework and way of coping to create social and physical environments that promote good health for all. Social determinants of health are conditions in our individual environments where people are born, live, learn, work, play, worship, and age that impact a wide range of health, functioning, and quality of life outcomes and risks. There is a model that connects all of these pieces together to understand the social, economic, or physical risks from these various environments and settings like school, church, workplace, and neighborhood. In addition to the more material attributes of place, the patterns of social engagement and sense of security and well-being are also affected by where people live. There are resources that enhance quality of life and can also have a significant influence on population outcomes. Some examples of these resources include safe and affordable housing, access to education, public safety, availability of healthy foods, local emergency and health services, and environments free of life-threatening toxins. We have to be aware of these factors which place people at risk for poor health, such as poverty. Also, challenges with health literacy, which the Affordable Care Act of 2010 describes as the degree to which an individual has the capacity to obtain, communicate, process, and understand basic health information and services to make appropriate health decisions, are very common for people living with mental health conditions. Social determinants of health includes understanding the barriers to care that people of color experience when seeking health care because of inherent bias, stigma, and racism in health policies and resources available. The differential access to goods, services, and opportunities of society based on race, ethnicity, or religion is built into our healthcare system. Community can be a supporter of health or a challenge to health. Think about your own community for a moment. Are there sidewalks? Is there access to green space? Is there easy access to health and wellness services? Is it safe to walk outside? Now, imagine the communities where your service recipients reside and ask yourself the same questions. Sidewalks, green spaces, access to care, safety, and you might think of other responses. Finally, be aware of a person's level of acculturation if they are an immigrant. Do they speak English? Do they understand the healthcare system and services that are present in their community? So now let's hear from you. What other lifestyle risks have you observed at your site? If you could just go ahead and enter that into your chat box. What are the lifestyle risks you have observed in your site?
So Michelle, we're seeing risky sexual behaviors or promiscuity, smoking, poor diet, discrimination, drugs, domestic violence, homelessness. Oh, they're coming in so fast. Too many people living in close quarters, more substance use, poor hygiene practices, lack of preventative care, sex trafficking,
Wow.
also sex workers, lack of transportation, paranoia about seeing doctors, poor nutrition. Let's see, so many things. Lack of access to education, etc.
Okay, thank you, Anna. I appreciate it. And thank you, everybody. Really appreciate you making this a more interactive style of presentation. And I just want to comment on the poor hygiene, which really I would not have really made the connections, but I was working with a housing provider a few years ago, and they were telling me some of the skin conditions that are really common for the people that were living in their settings. And I was like, oh, wow, that is definitely a hygiene issue when someone doesn't feel comfortable changing their sheets or changing their clothes. That could definitely lead to all kinds of challenges. So thank you very much. We do have a lot of issues that people face in terms of their good health. So let's switch it up a moment and get to health and mental health. And it's sort of, I like this graphic because it's sort of like a yin and a yang a little bit. It's sort of like we've got to have health and we've got to have mental health. Many people living with mental health conditions experience more health problems than people without mental illness, and they worsen with age. But the difference is for people living with serious mental health conditions, they're likely to have those health problems at an earlier age. And that's contributed to by use of medications and also the challenges to health related to social determinants like poverty, difficulty accessing care, provider stigma, and the things that we just discussed. And when the person has more health problems, they're likely to experience worsened psychiatric symptoms and likely increased risk of death. This results in situations where people who are aging with SMI or growing older may have more severe health conditions and worse care. There are also many unhealthy lifestyle behaviors like eating too much, smoking, and living a sedentary life. So all of these things are sort of interacting together. And if you just think about yourself for a moment, if you've ever had any kind of cold or flu or anything where you have a temperature, you could think about your own mood and how that works. Because you literally don't want to be around anyone. You might be irritable, you might feel sad, and you may wonder if you're ever going to feel better. So health and mental health are really, really interrelated. There's also some evidence that I feel like I should mention urinary tract infections. As a person gets older, people who have UTIs are at very high risk for developing delirium, and that can really pose a problem for their mental status. And also another issue I think we should mention is physical pain and the impact of symptoms and functioning. What does pain actually do for symptoms? And I think that, pain may make people more withdrawn. It may make people more irritable. It's hard to say. And some studies that I've read have suggested up to 1/3 of people living with mental health conditions experience pain related to some health problems, dental problems, or musculoskeletal problems. And we didn't actually mention oral health, but that's another area that Anne and I have been doing some research in, is the oral health of people with serious mental illness. And there's a lot of evidence that they have quite poor oral health care, and that has to do with insurance and access to dentists, and also symptoms getting in the way, and finances. So there are a lot of reasons why the oral health care is much poorer, including medications can cause dry mouth, which increases cavities and dental decay and things like that. So now we get to turn to recovery. We know that mental health and health are intertwined because we've been talking about it. You can't have good mental health without addressing physical health needs and issues. But how do we go beyond looking only at medical problems? How can we address quality of life and purpose and meaning for people living with mental illness? From the psych rehab perspective, we'd like to draw on understanding what is important to the person. What's the life they would like to return to? What are their hopes and dreams? How can we support people to live the best life that they can? Recovery is helping a person to live a good life despite the illness, and more time on their hopes and dreams than on managing their mental health. Got to put some colors in, I'm very excited. So let's talk about physical health and recovery and the interaction between all of them. SAMHSA identifies these domains and how they all are sort of working together to support recovery. We've talked about how mental health and health overlap a little bit. When we don't feel physically well, it can lead to all kinds of different emotions, and symptoms of depression or anxiety are quite common. In fact, I didn't mention that people with breathing disorders, COPD and emphysema and asthma, are at higher risk for anxiety disorder. So there is that in the published literature. People with cancer are at higher rates for depression. So there are actually some physical health conditions that are linked to mental health symptoms. But good health means not only overcoming or managing one's health problems and symptoms, but it's also about making informed, healthy choices that support physical and emotional well-being and just having a good life. A lot of you have talked about homelessness, which is an incredibly important point. For people to have really good health, it's important, and also recovery, it's important that the person have a stable and safe place to live. If basic needs are not met, like housing, food, and safety, a person will not be able to focus on the bigger tasks in their life, like finding employment, meaningful activities, and engaging with family and friends. Also, having some sense of purpose and meaning is key to a person feeling good about themselves and their lives. This idea comes from a general spiritual or philosophical perspective. What gives a person the sense of connection and personal meaning to each day so that they can participate in and perform meaningful daily activities while also having the independence, income, and resources to participate in society and be as independent as possible. And community is another important piece of this puzzle. For many people living with mental health conditions, they may be at risk of having fewer social connections and a greater sense of isolation. And isolation has been linked to depression and also to poorer physical health outcomes. So people actually die sooner who have fewer social support. So it's something that we really have to take into consideration and think about. Connections to other people, groups, or even pets are necessary for people to live a healthy life, and good social support is actually linked to better health outcomes. Having relationships and social networks that provide support, friendship, love, and hope are helpful to promote recovery, improve physical health, and live a more meaningful life. And finally, personal recovery goals are also part of the health and recovery connection here. We often talk about the importance of personal goals in psychiatric rehabilitation as a way to engage people, support them to live the life they want for themselves, and encourage recovery from mental illness. This means shifting mental health care to a collaborative model where people with mental illness take an active role in their own care and identify what they want and need to keep their valued roles of friend, mother, uncle, or partner. And health and recovery is an interesting thing because it means sometimes as health providers that we don't get a say in terms of what the purpose of a person's primary goal is. And when I think about this, I'm always reminded, I ran some health fairs for an agency a while ago. And we had a gentleman who was participating, and the nurse took me aside and said, oh, there's, you know, let's call him Joe. There's Joe, and Joe really needs to stop smoking. Can you talk to him about stopping smoking? And I was like, well, you know, this is really just a health fair. He's going to learn a lot about a lot of different information. So Joe went through all the different stations, and he stopped by to say hi to me. And I was like, how's it going, Joe? And he was like, oh, pretty good. I said, what have you learned today? What are you thinking about? And he said, oh, I learned some really important stuff. I said, oh, what was that? He's like, yeah, I learned that, you know, that I really got to watch what I eat, because watching what I eat is really, you know, it's really going to impact my cholesterol. And I'm kind of worried about that. I was like, oh, that's a really good thing to hear. And that was a really kind of important moment for me, because I realized that Joe really wasn't ready, which we'll talk about in a few minutes. He wasn't really ready to talk about his smoking, but he was really interested in his cholesterol. And often in health promotion, and I will admit I'm guilty of it too, I go in with my own agenda and I say, oh, wow, so you're a smoker, so you really need to address this first. And the person is like, yeah, no, I'm not really interested in that. Thank you, but I'm not interested. Goodbye. And then that closes the door to the relationship, and it closes the interest in health promoting behaviors. So using recovery as a way to really meet the person where they're at and connect with their what they think is important is really, really valuable in terms of health promotion, and it's considered one of the best practices. So let's hear from you now. I've been talking a lot, and I'd love to hear you and some of your ideas about how has poor health impacted your service recipients' personal recovery goals. So if you want to just take a moment, answer in the chat, how has poor health impacted your service recipients' personal recovery goals?
So we're seeing difficulty with motivation, difficulty working, pain often leading to use of substances for coping, poor medication adherence, recovery takes a backseat, delays recovery, difficulty getting out of bed, challenges with emotion regulation, anxiety, exacerbation of anxiety, health takes priority over other goals. Let's see, what else? Poor nutrition leads to poor oral hygiene. You mentioned that a little bit, some of the work we're doing in that. Isolation, difficulty achieving other goals because of the health, in and out of the hospital, so difficulty working on goals because of those interruptions, those kinds of things, lots of different things.
Thank you, Anne.
Mm-hmm.
Yeah, and I think you all have really addressed some of the primary concerns. One of our colleagues, Dr. Ni Gao, did a small study looking at employment goals and what got in the way of employment. And she did find that a lot of people reported that health concerns impacted a person's desire to look for a job, ability to keep a job. So I think that, you know, when we think about how to normalize life for someone, it's being active in their community, whether that's paid employment or a volunteer job or having a meaningful daily occupation. And when health gets in the way of that, that's incredibly discouraging for people. I also wanted to touch upon, someone was talking about getting out of bed, and you know, for many people that I've met living with mental health conditions, one of their goals is to live as independently as possible. And poor health often has a huge impact on that person's ability to live independently, to You know, for example, one issue that's come up in my consultation in the state hospitals here in New Jersey is our housing market is incredibly expensive, and probably there are people on this webinar who also live in those kinds of states, but it's very, very expensive to get a house or apartment or room or anything. I mean, it's very ridiculous. And as people are trying to get discharged from the hospital, there are often steps that they need to get to the second floor or to the basement to do their laundry. And for the units housing people like over 40, sometimes that's really a barrier for them to get discharged or to be able to live as independently as they would like, because they can't do the steps, and or they have difficulty with the very basics of getting out of bed. But if you think about it, I'm thinking about it because my father fell and broke a vertebrae in his back. And after that happened, he had incredible difficulty bending over and putting on his socks, which sounds really funny, but it's not so funny actually. If it's someone who, in order to live independently, needs to be able to dress themselves, needs to be able to bathe themselves, need to be able to prepare simple meals. So that definitely really hinders a person's other goals. If their physical functioning is impaired in some way, and also if they're spending most of their time focused on physical health and well-being, you don't have time. It's like managing health can become a full-time job. And I'm thinking about people who might be on, you know, dialysis or something. That's like a full-time job to manage that, and diabetes to some extent as well. Particularly if it's a little bit out of control. So you all have come up with some great suggestions. And also, I think pain does impact a person's ability to achieve their goal, particularly if they're running into substances to manage the pain. But even in some of the interventions that we did in the community, we had some physical activity interventions. We'd ask people to participate in very simple, easy movements guided by a physical therapist, and people would just have such extreme difficulty doing things like standing up out of a chair or bending over, or things that we all, I guess, take for granted, and maybe I take for granted, or if you don't have that pain or you don't see someone experiencing those problems, you may not note that. So I think it's really a great discussion to have with the people that you're working with. It sounds like some of you may already be having these conversations of what is your health doing for your recovery, basically. Think about that for a moment, and ask the person to consider what impact health has on the life that they want to live for themselves. Thank you, everybody, for your participation. It's really fascinating to hear the kinds of things that you're running into. So here's what I also was thinking about. Poor health limits recovery and desired roles. And when I think about desired roles, I'm again thinking about, you know, worker, friend, partner, mother, cousin, churchgoer. These are all roles that a person might want. And one challenge is that the stigma that people with mental health conditions face. People with mental health conditions report that health providers are impatient, that they blame their health symptoms on psychiatric symptoms, and sometimes even refuse to treat them. And research shows that people with mental illness are less likely given certain tests or treatments than people in the general community, and they're also less likely to have a primary care provider. But having significant health problems can also impact a person's abilities to seek or obtain a job, integrate into the community, or live the life they want. And that's why I was thinking about discrimination and sort of the ball in the chain of a health problem, because it kind of follows you wherever you are. I'm not, it's not a funny matter, but it's just sort of amazing that the level of health problems that the people that we serve experience, it's overwhelming to imagine. And I know you know that. I know many of you know that. So, and even poor health itself, people with other kinds of disabilities. So if they are someone living with a mental health condition, and they also are a wheelchair user or a cane user, or, have a vision impairment or hearing impairment, those disabilities also impact on the level of care and discrimination that the person might experience in mental health settings, in health settings, in community settings. So all of those things also contribute to the person sort of being connected to having difficulties connecting to their community. So let's talk about the wellness approach to health. Health can influence recovery, and we need to address health in mental health settings. But what are some strategies to address health from a recovery orientation? It's a little tricky because physical health is often about the problem, the treatment, and the cure. And the recovery movement is about acknowledging that there may not be a linear relationship between getting treatment and improving. And many times there's no clear-cut cure for mental illness. You know, if mental illness were as easy to manage as high blood pressure, people would take the medication and that would be it, which I know it's much more complicated than that. But we need a framework that can be motivational, take into account recovery and growth, but will also encompass all the areas of health and the determinants of health. I think that the 8 dimensions of wellness developed by Dr. Peggy Swarbrick and adopted by SAMHSA is a really great place to start. The model goes beyond medical treatment and illness. It's holistic and inclusive of many areas of a person's life and encourages personal responsibility. We want our service recipients to embrace their life and go beyond thinking of themselves as patients. So let's just do a quick review of the wellness model. And wellness is described as the active process through which people become aware of and make choices towards a more successful existence. More simply put, wellness is about striving to be as healthy as you can be in all aspects of your life. The model has 8 different areas of a person's life that need attention and balance, including physical, emotional, social, spiritual, occupational, environmental, intellectual, and financial. The idea is that all of these areas overlap and interact and contribute to who we are and to our overall well-being. And if we neglect one area of wellness, we will struggle because each of these is very important to feeling healthy, recovered, and connected. And you can learn more about the recovery model from the SAMHSA website. So health and wellness, when we're going to use a wellness approach, we're acknowledging that health is more than in the absence of illness. It encompasses multiple areas of our life. Being well means a person is focused on improving their life in a lot of areas. To use an example in my own life, when I go for a bike ride, I'm promoting my physical wellness through movement, but also my social wellness because I ride a tandem with my husband. I also promote my spiritual wellness because being outdoors and connecting with nature is a way I find purpose and meaning. Biking is also an intellectual activity for me because I need to focus and attend to many details at once, avoiding potholes, navigating the direction to focus, and communicating what's happening to my partner. By reinforcing the interconnectedness of our wellness to the people that we serve, we can help people see the importance of their health and explore how to make health a priority for each person. Wellness encourages personal responsibility or agency to move forward in one's life, to go beyond the role of patient or client and move into recovery. This is incredibly powerful for a person to shift their thinking, build confidence, and connect them to the hopes and dreams they have. Lastly, wellness gives a framework to understand why good health is important to the individual. What motivates the person to balance their health and wellness? It may be their friends, family, significant others, relationships to a higher power, or even pets. I used to do a wellness presentation because at the time I had 3 cats. All of my cats were about 15 pounds, and I jokingly said that they were part of my wellness plan because I had to carry 45 pounds up and down the steps if I needed to take all 3 of them to the vet at once. And then people started recommending that my pets develop their own wellness plan, which, you know, that's probably true. Anyway, we do need to know why health is important to each individual and ask people, why is your health and we said this before, but I think it's worth mentioning again. Why is health important to you? What is it that you want to do with your life? How do you want to live your life? And what does good health contribute to that? So let's look at this, another wellness example. Maria has 2 part-time jobs. Recently, changes have meant that her workload has increased, and now she works 7 days a week, about 80 hours a week. The increase in work is positive for her financial wellness. She's making money. Her occupational wellness, she's got 2 jobs, is looking good. But hold on, how does that impact the other areas of her wellness? And I know you know the answer to this, but her social life and wellness have been impacted. She hasn't been reaching out to her friends. She's tired all the time and not interested in catching up with her family and less available to her partner and children. She is also starting to wonder what's the purpose and meaning of her life. You may know someone with a similar story. You may be the person in this example, or you may work with clients who have a similar challenge. So it's important to gain some perspective about your health and wellness and the interconnected of these things. Whoops. So now we're going to hear from you for a moment. Can you think of other examples of how these wellness dimensions overlap or influence each other for either, for your service recipients?
Michelle, can you repeat that question?
Oh, sure. Can you think of other examples of how these wellness dimensions might overlap or influence each other, particularly for your clients or service recipients or the people that you see? How might the wellness dimensions interact or overlap?
Great, thank you. So somebody said they see mobility as the 9th dimension of wellness, and that if you don't have that, it can really be a barrier to the others. Another comment, when one area is not taken care of, the stress leaks into almost all the other realms. Also, less interest in activities. When taking steps to improve physical health, sometimes I see that it improves mood. Poor economic situations may lead to poor nutrition. Losing employment can bear on occupational, environmental, others. Let's see, what else?
Well, that's good. That's good, Anne. Wow, you guys are thinking. Yeah. I love the idea that mobility is the 9th dimension. I mean, that is really powerful, because I think if we think about mobility as like, can you walk? But also I have a family member who has a vision impairment, and that is a big barrier to mobility in terms of getting from point A to point B. And I think that a lot of people with mental illnesses experience mobility challenges, and it could be, not living on a bus route. It could be having, bad arthritis in their knees. It could be, I've seen this a lot. You probably have seen this a lot, severe obesity. And that means that it's really hard for people to walk, even a short distance. And I think that stress does interplay with all those different areas. Absolutely. And it makes people less able to connect. So thank you, everybody. I really appreciate the feedback there. So let's quickly go over some of the KSA of wellness. KSA is knowledge, skills, and attitudes. I was thinking about this. What do we need for wellness? You may already be well equipped, but I was thinking we need to have a basic knowledge of the framework and attitude, knowledge of the framework and how they interact. And it sounds like you all have some really good thoughts about how the dimensions are interacting for our clients. We also need the skills or the ability to explore interests and strengths and approaches to personal goal setting with others. Engaging a person and encouraging empowerment, that takes a certain skill set. Using motivational enhancement strategies like MI or motivational interviewing, and connecting individual recovery goals to multidimensional wellness in each dimension. And the attitudes, when helping with someone to work on their health and recovery goals, we should be focusing on empowering the person to do things as much as they can for themselves. We have to hold the hope that they can change and believe that change is possible, and believe that health is more than taking medications as prescribed. Some strategies, you all may be familiar with some of these. Shared decision making is a wonderful strategy that can be helpful. It is a process by which people come together and their supporters. So it's a client or a service recipient or patient, however, what language you use, and their supporters to make decisions, select tests, treatments, and care plans based on clinical evidence and balancing risks and expected outcomes. I really love there's an Ottawa decision aid. Ottawa, like the Canadian province, Ottawa Decision Aid, I find there's a great handout that is really helpful to sort of explore all the aspects. And it's quite helpful because it's very matter of fact, what's the decision to be made? What are the risks? What are the expected outcomes? What is important to the person or not important to the person? Also, learning how to set goals where you really explore what the person's interests and desires are, and try not to have that push element. It's very tempting to be like, wow, you're coming here, you're smoking, you're overweight. These are clearly the issues that you want to work on. That may not be what the person wants to work on. And we really need to sort of follow them wherever they go and try, to engage them. RAP plans. I hope some of you know about the Wellness Recovery Action Plans developed by Mary Ellen Copeland, which is a relapse prevention plan and identifies sort of daily self-care strategies and a maintenance plan, triggers or things that might make a person feel upset, early warning signs or the behaviors that show a person isn't doing well, or when a person is very close to crisis and managing a crisis. I think RAP plans would be really well adapted to physical health. And I believe that they probably have been. I think they have been. So using RAP or self-management strategies to handle both physical and mental health conditions, I think is a great strategy. Also incorporating these health factors into any of the relapse prevention plans that you use or talk about in your settings. We also have some strategies that are more organizational level, programming level, and practitioner level. We should always include stakeholders, and the stakeholders can be the people served, it can be family members, also your staff. Getting staff on board can be one of the biggest challenges. I was part of a program evaluation of a modified Tai Chi intervention at the hospital, one of the hospitals, and the staff were not in support, and they did not like the program, and it was, not well introduced, I guess, to the staff, and the staff would do things like go in the middle of the Tai Chi activity and slam the door and scream out people's names. And it was like, please, and once the staff settled down and realized that people, the service recipients really enjoyed the group, and the unit got quieter and the volume went down, they were very supportive. So it's quite important to get everybody involved at every level, whether that's community setting, inpatient setting. Family members also can be an incredible support. And also you need your staff to be on board if you're talking about things like smoking regulations and vending machine changes, because if you don't have that support, people might not be helpful to the cause. Also offering a variety of health promotion activities, including staff programs. So making sure that it's not the one health and wellness group. I've been to many outpatient mental health providers that they have the one health and wellness group where they alternate talking about diet 1 week, exercise 1 week, smoking 1 week, sleep 1 week. The idea is health and wellness has to be infused into all of our interventions. It may take a little creativity to think about how to do that, but it's quite important. We also need to, consider integrating health process and procedure. So you're probably already doing this. And when I started thinking about health promotion in 2007, wow, that's a long time ago, they were not the reimbursement strategies and the systems like the SAMHSA behavioral health homes, and there wasn't a focus on physical health and wellness, and that's slowly changing, but I think there's still challenges getting health services covered by behavioral health providers. In some areas it's better, in some areas it's worse. Also, framing health as a key feature in recovery. So reminding people that their health is just as valuable to their recovery as is taking their medication. I mean, you know, medication adherence is one piece, but it's also caring about yourself and appreciating yourself and investing in yourself enough that you're willing to get out of your comfort zone to stay healthy and well. And performance improvement is a great strategy to collect this information. Having health fairs is really, it's a wonderful way to get to know everybody in your setting, where you sort of bring outsiders in, or if you have a nurse, you sort of run these health fairs and you collect lots of different information, you know, like blood pressure, weight, BMI. You can even do some fun, you know, physical assessments of functioning. So there are a lot of different ways that you can use your existing structures to support health and wellness. Also, collaborating with the community is very important. There are a lot of nursing, it depends on the state, depends on your community, but you probably know your services already, local-wise, health clinics, churches or community centers, and using the available resources. Here in New Jersey, we have public health nurses who are willing sometimes to go out and give presentations, and that's been wonderful. Also, SAMHSA has been wonderful in promoting the behavioral health homes, and a lot that's basically providing a model of care where the behavioral health organization takes over sort of care in a lot of different ways, whether it's nursing services for one aspect of care, or providing linkages to a clinic, or transportation to a federally qualified healthcare center. So there are a lot of different models. Also, training all the staff is really important, and continuing like booster shot training to make sure that people understand sort of the importance of health and wellness and the commitment of the agency to health and wellness from a recovery perspective. So it's not about taking your medicine and the injections. It's about, why should people take the medicine? Why should they focus on their health and wellness? And how can we engage people to be interested in this sometimes painful topic? Additional programmatic considerations would be finding good materials. And I've spent many years looking for good materials. It's really, really important to think about the materials you use, because that could be a way to bring people in or a way to push people away. And that's everything from, I've seen health groups that was, you know, a nurse reading from, not to pick on nurses, but, you know, a nurse reading from a nursing journal aloud to a group in an outpatient mental health setting, which was like, what? And then, you know, another outpatient mental health setting, a rehabilitation staff was reading from an abnormal psychology book. So I think, you know, sometimes we're busy and we're rushed and we don't have time, but it's really worth developing creative methods to engage people that meet their specific needs. You all brought some wonderful population specific issues in terms of health needs, HIV, homelessness, sex trafficking. All of those areas are things that you may need to pay special attention in your settings, and tailor your approaches to the population that you have in your program. I also want to mention the use of peers. I was involved in working with Dr. Swarbrick's peer wellness coaching years ago, in the development and training of that. And I've had peer wellness coaches in some of my projects. And I think that peer advocates and peers are amazingly important. And there's some wonderful materials out there, including the whole health, oh gosh, I'm blanking on it, but it's WHAM is the acronym, WHAM. And if you, SAMHSA has put out the WHAM booklet, and that's for peers to promote health. And I think that's a really wonderful resource. And offering a lot of choices and considering readiness. Readiness to do what? think we've talked a lot about these things. I do want to mention focusing on skills. So skills-based health groups, like how do you walk safely? How do you prepare a healthy meal? How communication techniques? How do you speak to your doctor? How do you advocate with your nurse? These are all skills types groups that are really helpful and valuable for people. A book that I really love, and you may know about it, is skills training, social skills training for schizophrenia, and the primary author is Bellac and Musser. And that is a really, really helpful book because they have all kinds of social skills, but there is a chapter on talking with your doctor, which I think is really, really helpful. Specific interventions, these are probably things you're already doing, but asking permission using a motivational approach. May we talk about this? Getting the person's views and inputs, and really trying to stay focused on the positives, because there's really nothing worse for a person. I don't know, I think most of us don't want to hear what we're doing wrong. We want to focus on what we're doing right and maybe how we can move towards something that we want. We want to enhance the person's ability and confidence. And the last one is so hard. We have to model healthy behavior, which is a challenge. And I usually, when I present to consumer groups and peer groups, I often tell everyone my challenge with Krispy Kreme donuts is real, everyone, and getting to the gym as well. So I think that it's really important to own your own health and wellness challenges, so that people aren't looking at you like, you're telling me not to smoke, but I see you and I smell the smoke on your clothing when you walk outside behind the building and take a cigarette break. It's not extremely motivating for people. So sharing the challenge, it's not to say that you have to be perfect. None of us are perfect, of course, but to say, you know, I'm not a smoker, but a person could say, you know, I am a smoker. I've been trying to cut down. It's really important that we cut down because of X, Y, and Z. So these are some thoughts. And also ensuring a person involvement in choice, using shared decision making and believing that change is possible. So all of these things I think we've talked about. I do want to just spend a moment talking about readiness, which is a concept I hope you're familiar with from Prochaska and DiClemente's Stages of Change. And it's readiness to do what exactly? And that's talking about readiness from a health behavior change, motivational interviewing perspective. Readiness for goal setting should be applied by considering where the person is and how ready they are to do something. And it could be that they are totally ready to address moving more and decreasing sedentary behavior, but they don't want to talk to you about their, you know, I'm just going to use myself, their Easter egg addiction, right? They don't want to talk to you about that. They may want to talk to one area or the other. So sort of understanding where a person feels like, you know, using the ICR ruler or importance, confidence, and readiness, asking the person, how important is something like diet to you in your life right now? How confident are you that you could address this issue? And how ready do you feel? So interventions should be varied and address all different levels of readiness. I was doing this smoking cessation work with Dr. Jill Williams. And as part of that, I went and did technical assistance throughout the state. And one very recovery-oriented organization I went to, we were like, okay, call it the Learning About Healthy Living group. And I went, and they were like, well, our members voted, and they just said they wanted to call this the We're Not Going to Stop Smoking group. And I was like, okay then. That was a big readiness reality check. So you do have to sort of have open conversations about what people are ready to do and what they're not ready to do, and offer and tailor your health promotion interventions for where the person is at. So offering things for people in pre-contemplation, for people who are not ready to change, offering groups for people in the action phase, and offering groups for people in the pre-contemplation phase. So as kind of summary of all of these different practices, I really recommend that each organization think about an assessment of programming, or even if you're just a practitioner, to think about the groups that you run that address health and wellness. The best practices suggest that they are a minimum of 3 months, preferably longer, that they include peers. There's a connection to the community and community services, so that all of the health information doesn't come from one source, that it's also available outside of mental health services, that there are also regular screening initiatives that look at blood pressure, weight, BMI, glucose or A1C values, that motivational interviewing or motivational strategies are used to engage people so that people can own this process. At a minimum, looking at nutrition, movement, and smoking, but including so many other issues that we've been talking about: infectious diseases, how to stay healthy while you're living on the streets, or strategies to practice good hygiene while you're living on the streets, or whatever your individual service recipients or clients are managing. Also, to consider self-management programs. I didn't talk a lot about that, but those would be things like illness management and recovery. There is actually, Dr. Stephen Bartels created, and Kim User created a wellness management and recovery program that is linked to the IMR, that's run by a nurse. So using some kind of self-management module is really helpful. There's also diabetes self-management education materials freely available on the internet. The internet has really opened up, and I always go to healthfinder.gov because I find, there's just a lot of weird stuff about health, and I like to stick to the government and SAMHSA's, CDC. They're wonderful websites for getting the best kinds of information. So in summary, I do want to leave a few minutes for some questions. I think we've got a few minutes left. We covered recovery and the connection to physical wellness. We also talked about the health problems and accessing care. We went over wellness as a framework for health and how that might be useful. And we talked about recovery and recovery goals in health, and how those can be really important to engage a person. And finally, we talked about strategies to assess the organizational, program, and practitioner level methods to encourage recovery-oriented health promotion activities. So I think I want to wrap it up there and say we can either continue with a question or do question and answers. And what do you think we should do?
Well, we have a couple questions that have come in,
okay,
that I wanted to pose to you. If others have specific questions that they'd like Dr. Zechner to address, they can type them in the chat box now. And we'll get to as many as we can. But I wanted to start, so one of our participants commented earlier on, while you were talking about some different physical activities people could potentially start to do, you mentioned things like walking or standing, those kinds of things. And the comment was about being sure to be inclusive of those with mobility disabilities. I thought it was a really important point, but the other thing that I thought you might be able to elaborate on was, I know you mentioned briefly the Tai Chi Easy intervention that you were a part of at the State Psychiatric Hospital, and I believe you were able to do that with folks who had some mobility issues. So I wondered if you could just talk a little bit about that experience.
Absolutely, and I'm so grateful for bringing that topic up. And that was ableism at its worst. I do apologize, but when we're talking about mobility for people who may not have the range of motion of everyone, that they are wheelchair users or cane users or have other kinds of disabilities or movement issues, things that might be considered basically any movement that the person can do. I really think about it from my perspective as harm reduction. And that's my own perspective, is that any movement a person can do, if they're seated, they can move if they are able to move their arms, they should definitely move their arms. There are, in fact, some wonderful adapted videos available, and I'm sorry, I don't remember off the top of my head. You could Google it, exercises for people in wheelchairs, or strategies for people exercising who have vision impairments or movement difficulties. One resource is also the University of Illinois at Chicago has a large grant funded by Neidler, and they have some videos that are available, and I think that some of those are adapted. But let me talk a little bit about the Tai Chi Easy study. We were able to publish that, so it is an article that we published. I think it came out in the American Journal of Psychiatric Rehabilitation last year. And that project, I tell you, I was amazed, because it focused on 4 geriatric units in the hospital, and one of those units, everyone pretty much had a mobility difficulty. Not everyone, but I would say 80%. So people were not only in wheelchairs, they were using walkers, they were using something called a geri chair, which is a supported recliner sort of thing. And the amazing thing is, it's all in how you adapt to the individual's needs. So the facilitator would go to the people who were in a geri chair. I'm just remembering one individual in particular, and demonstrate some of the easy movements with her arms and the breathing techniques. And it really didn't require anyone to stand up or walk. It required just listening to music, moving one's arms, breathing. And it really was remarkable that almost everyone who attempted was able to participate, whether they had a brain injury, whether they were, basically in a geri chair or in a wheelchair. So that was pretty remarkable. So I encourage everyone to look up adapted physical activity, because there are resources out there that are pretty wonderful.
Wonderful. Thank you so much. Couple other questions if we have time. So there was a question that came in about sort of trying to balance taking into account social determinants of health and wellness. So specifically the economic determinant. I didn't know if you had any thoughts. So the comment was, interventions for promoting wellness often don't adequately take into account social determinants of health. Do you have any suggestions around approaches that might help sort of find a happy medium between the two?
I think that's a really good point. And it makes me immediately think of, access to a lot of programs require money and health literacy and a lot of things that are people in living with mental illness struggle with. But one way I see to address that is individualized services. Really understand the individual that you're serving and you're trying to help, and trying to kind of create a mosaic of services that can strengthen and support the person's ability to promote their health. And also just being aware, I think a great example is diet, because, we're told to eat a lot of, eat the Mediterranean diet with lots of olive oil and fresh vegetables. But the challenge is that costs money. And so the changes may have to be extremely minimal. I worked with a group of folks who lived in something we call residential healthcare facilities. And I don't really know how, it's just a large congregate housing for people who have psychiatric conditions, and their meals are provided and they get access to a nurse, let's say once a month or something like that. And in those settings, people have no say over the meals that they receive, pretty much, and what are the choices. And I've talked a lot to people about their choices. Is there dessert offered? Can they eat less? What kind of portion sizes are available? Can they ask for a half a portion of something, or can they skip eating the bread? Or one person gave the example of having 2 bologna sandwiches for lunch, and they decided to remove the bread from one of the bologna sandwiches and put the extra piece of bologna on the other sandwich. So these are really real and important considerations, and I don't think there's any one easy answer for this, other than really getting to know your client and their needs, and trying to talk it out with them to see what options might be available.
Thank you, Michelle. And I see that we're right at 2:30. We've had a lot of participation from those in attendance, and we're really grateful for that. I'm sorry we won't have a chance to get to all of the questions, but if you have things you really want us to address, please feel free to follow up with an email. Everyone will receive an email from our program, our project coordinator, Kati Rivera. She'll send the links that will take you to the slides, Dr. Zechner's slides, also a recording of this presentation, as well as a link to our brief survey. So if you have questions, concerns, comments, if you want to provide us any particular input or feedback, we'd be happy to hear from you. And if you can, I encourage you to utilize those links that Kati will be sending out to complete the survey and also to access the resources. So again, thank you so much for your participation. We hope you're all well and taking good care of yourselves during this challenging time. And thank you to you, Dr. Zechner, for the wonderful presentation.
Thank you, Dr. Murphy.